So welcome to Her Body and Mind. Today is our second episode of our 3-part series on perimenopause. Today is going to be, is it perimenopause or something else? So Ciera's going to start with just walking us through assessments, and we're just going to have a conversation about what it is, what it isn't, and how much overlap there is.
Very good. Let's dive in. So with assessment in this phase, it's really interesting because I would say majority of women coming into my office, they'll say, I think something's wrong, something's off. Can we test my hormones? And I have to break their little hearts and say, no, we can't. Because reality is that we actually don't test the hormones that you think we test in this phase. So usually when women are coming in, they say, let's test my hormones. I'll actually ask them, well, what do you mean? What do you mean by hormones? You tell me what you mean by hormones.
What you know what to say,
right? And so I just want to get an idea of what their knowledge is in the area. And they're like, well, I think something's changing. I feel weird. They'll describe some symptoms. And then I'll kind of say, well, usually when we're talking about this phase and stage, we're talking about estrogen, progesterone, and then some women are also talking about testosterone. And reality is that in peri, we're still either getting regular periods or they're starting to become a little bit more irregular. But because things are so erratic, it doesn't make sense to test. And I mean, there's a lot of reasons, but if we're just putting into a tiny little nutshell, because it is so irregular that you could test your hormones one day and then the next day they would be completely different. And you could still think that maybe you are in your follicular phase of your cycle or your luteal phase, but your body doesn't agree and it does otherwise. And so to test those hormones, whether it be serum or salivary or urinary, you could get a different reading day to day, week to week, month to month. So it's not really giving you the information that you're hoping to get, though you want to validate how you're feeling with some. It's hard to then to tell women actually, I can't give you this, but I can confidently, with my clinical skills and history-taking ability, tell you exactly what's going on without a test.
Which is what we want to talk about today is what are those skills and how do we assess it? Because I hear it too in my office. People will be like, oh, I just need to get my hormones tested. I'm like, I think that's how it works. I don't think we can test. And the only reason I know that is because I'm best friends with you. But I thought that initially too, right? That it would just be like a blood draw and then I would know what up and then have this perfect treatment plan, which is interesting because that's kind of mirrors a lot of mental health stuff too, is that there ain't no test for most mental health conditions, right? So you have to use that clinical skill, which is what we're going to talk about today with assessing for what is the complex thing, perimenopause.
Yeah. And just an aside is you brought up mental health and a lot of people who are on prescription medications like SSRIs, we're not testing their serotonin or their dopamine once they're on these medications. We're using their clinical response to those medications to then dictate how we adjust levels. And actually using hormone replacement therapy is actually no different, whether it's in perimenopause or in menopause. And I think looping in now social media to that, a lot of women are told on social media that they should get their hormones tested. Social media, and that's not the truth. So yeah, let's jump into how do we go about figuring out how do we assess if someone's in perimenopause? And I think that if we go back to the definition of perimenopause, it would make it kind of confusing because if we consider someone being in perimenopause being that they have irregular periods at this phase in life, then again, they would never get assessed for perimenopause to begin with. So really, we're looking at what has changed. So I always ask them well, what happened to make you think that, you're in perimenopause? Because there's usually something different. They're I used to feel like this and now I feel like this. And so we're looking at what has changed and when did that change happen? So how long ago? And then at that time, so if they say, well, it was about a year ago, then we go back to a year ago and then we figure out okay, what was going on a year ago? Was there a lot of stress? Was there some sort of event that happened? Or was there other hormonal changes that happened around the same time they started noticing changes, but they didn't relate it to their other hormonal shifts? For example, maybe their PMS got worse, but then I asked them, oh, well, did your periods get heavier around that time? Did you start to notice more flooding? How's your sleep? Did your sleep change around that time? And then they put it together like, oh my gosh, yeah, all that other stuff was going on as well. Or they'll say like, oh, like my mom was in the hospital and then I was working with my kid and getting a diagnosis of ADHD. So there was a lot going on. So we really have to understand their environment as well as their own physiology as at the onset to then determine if are to be in perimenopause and did it start then.
And that's where I think this is such a good topic for our podcast, which is trying to bridge that gap between mental and physical health, because particularly with something like perimenopause, there is so much overlap, whereas being a woman in general is a complex thing. And so for having these stressors, or we're in the middle of a divorce, it's easy to miss both, I think. It's easy to miss it on my side as a therapist, and maybe it's easy for doctors I hear it a lot. My patients or clients just get thrown SSRIs or different mental health medications, and perimenopause is never even discussed with their GP.
Yeah.
So the overlap is what we're going to try to talk about today.
Yeah, totally. Yeah, so you kind of need to work with clinicians that understand that there might be a referral down the pipeline when it comes to, okay, like, well, in the example that I just highlighted, like maybe that there was all the physical changes plus she was dealing with the environmental changes that was going on in her life. And therefore, like, maybe she does need some support from a counselor because she's still dealing with that particular situation, but also her physiology from allowing her to manage that situation as well as she would have if she was in a different phase. So yeah, there's a lot of interconnectedness with whether you're a GP, naturopathic doctor, and then referrals to counselors, psychiatrists, etc. Now, going back into my world, well, perimenopause is a phase of life. We know this, and it's not just a phase where you're experiencing perimenopausal symptoms. Your other pieces of your body are changing, and so I'm often the bearer of bad news. I'm like, okay, well, we can't test your hormones, but what I do want to look at is your cholesterol, your blood sugar, your thyroid, your B12, your vitamin D, your iron. So a lot of metabolic shifts can come along with this stage of life. So we know that you become more insulin resistant. We know that your cholesterol can start to rise in this phase of life. So we want to, at age 40, actually assess like your baseline for everything, because in the next 10 years, so much can change, and we want to know if things are progressing in a negative way so we can intervene before it becomes a problem from a cardiovascular metabolic point of view.
Yeah.
And then going into more things like thyroid, B12, iron, vitamin D, these are deficiencies that could mimic some of the symptoms of perimenopause. So we want to ensure that those nutrients are optimized. Otherwise, you are going to have some crossover with presentations with low iron, B12, iron, anxiety, depression, low motivation, even difficulty with sleep. There's a lot of different symptoms that we need to suss out. Like, is this also a contributing factor to what you're experiencing? If you're a female in perimenopause and your periods start to get really heavy, you're going to have low iron. That's going to be a part of your picture. So that needs to be part of the work of those things too are really important to look at the person holistically and making sure that they get the appropriate care that they need.
Which I think is so tricky when we talk about social media and some of these like sweeping, generalized, easy, quick fixes, whether it's for perimenopause, mental health. It's just like, just do this, like get your hormones tested, it's this, or it's your mental health, you have to do this. Is like what I'm hearing you say is that it's a whole bunch of things that you need to kind of use like deduction for to separate, okay, it's not this, it could be this. And so it's a complex puzzle.
It's complex. And something else I didn't notice as well is that family history matters too in this. Like if we're talking about now we're dipping into like cardiometabolic health and diabetes, like most definitely, because we know that genetics plays a role in that. So understanding someone's family history also then dictates slightly, what we're going to be looking for in the labs and then what levels are acceptable versus aren't. So yeah, that's another piece of like this history and assessment and knowing someone's history, because I mean, I've had so many females as of late being like, yeah, my dad passed away at 50. My mom passed away at 52 from these like events, being heart attack, stroke, etc. Like these are real things that happen at young ages. And this is the time to be proactive and preventative and reduce risk for women.
So it's like this episode is about what is perimenopause, but it's also this phase of life. And I'm going to talk about that too, is this space or like opportunity to start looking at like the whole picture. Because like you said, at age 40, stuff starts changing. We become different.
Yes,
Older.
very much so.
Okay.
So I think that's kind of like my assessment side of things. I think that you wanted to talk a little bit about this side of, on your side, what happens if a woman is like, let's say in between the age 35 and 45 coming into your office, you know, she thinks she needs counseling, but you obviously know she's in that age range where there can be hormonal shifts going on. Like, what is your like procedure? What are you looking for in those women?
Yeah. And I think it's similar to you. I think it's all about that assessment. So that like initial intake is so critical, and it's critical that it's done well to figure out what's been going on, how long it's been going on, when did it start? Did it get worse? What are the situational factors now? And then what are the symptoms and how do they present?
Mm-hmm.
Because a lot of people will just come in and I can't count how many times I've heard this. Like, oh, okay, like, welcome here. Like, what do we want to do? Like, why are we in therapy? And there's like, I just want more joy. I just want more happiness. And it's because there's so many pieces. There's so many complicated factors that have stolen their joy or their happiness. And so that assessment piece is critical. So for example, like if we're talking about, is it perimenopause or something else, being able to differentiate, say, what is trauma, which is what I specialize in, versus what is perimenopause. And so those are going to be very distinct things. But if you have a trauma history, not being in perimenopause or not having like massive hormonal shifts might have allowed you to buffer some of those symptoms in a different way. So maybe your nervous system's always kind of been in fight, flight, freeze, and it's been, a little bit there, but we only know what we know. And so it's never, so many people think their symptoms are normal until they're exacerbated by a life event or something like perimenopause. And so when someone comes in and they're in an age where they could possibly be in perimenopause, one indicator for me is like a sudden onset of symptoms, where if they're like, I've been good, like I've never really had mental health stuff, and just like all of a sudden they're really anxious, or all of a sudden they just like can't get out of bed, that's a clear indicator that it might be something hormonally. But what I tend to see is that it's both. I think that people with trauma, unless they've had some acute, terrible thing happen to them that we need to manage in a very like emergent way, it's usually a history of trauma where they've had symptoms, but now those symptoms are a lot more pronounced. The same thing happens with new moms, actually, in that postpartum period. I see a lot of like massive flares of trauma that they thought were okay. Same thing happens for a lot of women after men. After a car accident, they were like good until something made them feel powerless, and all of a sudden all their resources are gone. And this is kind of a phase like that. So the assessment is being able to tease apart maybe where I need to refer also to a doctor, like a wonderful doctor like Dr. Ciera Fox here, to be also talking about the hormones. Because I think the thing we talk a lot about is like knowing your lane. And I think when we look at education, both for clinical counselors, which is all I can speak of, that's not part of the training. I don't remember a moment in graduate school when they were like, this is perimenopause and menopause, and like we need to know about the physical like reality of what's happening for women so that we can know when we're outside of our lane. Like, and nobody knows. And so for me, I think a big part has been knowing you. And I think that can be true both ways. Like, you know so much about trauma and all of these different things because you know me. And so I have this knowledge that I don't know really, unless you're going to look for it as a clinician, how you know. But if I'm treating a woman who has mostly perimenopausal symptoms, and I'm just like getting her to explore how she feels, I'm doing her a massive disservice. And so it's really about knowing when to refer and how to assess.
Yeah. I was just, as you're talking, I was reflecting on my own education, trying to figure out like, or remember when I was taught about counseling and just going back to training. It's interesting because it comes back to training and knowing like when to refer, when not to refer. But in our, if anybody knows anything about naturopathic medical school, like we're taught everything. We're taught massage, we're taught acupuncture, we're taught counseling. And then there's obviously like nutraceuticals, herbs.
I didn't know men's had like massage.
Yeah, a whole course, course massage. So like they kind of like dip into everything, and then less on the massage side, but we did do like 3 separate courses in counseling. But it's unfortunate because the takeaway is that we have the skills to navigate and to support people in this like sense of counseling, but we don't. It was a lot of like, your patient is the person sitting in the circle and you're sitting in the square, and you have to be able to go into the circle with them sometimes, but then step out and parrot what they're saying and suggesting active listening and what else, journaling, write stuff down. Like we didn't learn about EMDR, any somatic therapies. Like, so again, like I think a lot of NDs leave school thinking that they have this skill set to walk people through trauma or support them in that way so they don't have to refer.
Yeah. And
that can be the farthest thing from the truth. Now, knowing like being friends with a counselor and knowing what she does and the inner works of her sessions, like you can't compare the two. And so knowing your lane and staying in it is super important. But if you've been told in your training, in your school, that you have this skill set, you have this very skewed view of when to refer.
Which makes it odd for the patient or client. So we're out there now, all of us women are out there trying to figure out our symptoms. And so if you're not having some of those like classic symptoms, like it's unlikely, and I say this because no one's ever said this to me, like I have hot flashes, let's talk about that. That's a kind of well-known one.
Yeah.
But for those dips, like I shared in our last episode, like I wasn't super stable a few days before my period. Like the rage was intense. And so if I'm saying that to a counselor and that counselor doesn't have the knowledge to say like, oh, like if that's the primary symptom, we should also be getting you in with a doctor who can help assess this well to look at if this is perimenopause, especially if those are some of the primary symptoms. Because for me, wild rage was the main one, which does mirror a lot of mental health stuff.
Mm-hmm.
So I think the main point is that it's really hard to be out there. And I think that's pulling it back to the main reason of this podcast is how do we give people the information to know what do you do with some of these symptoms? And the hard answer isn't that there's not probably just one thing to do. It's looking at kind of your whole, I like to call it like a puzzle piece, and like what pieces need to kind of click into place for the ultimate goal for humans, for us to like live with greater ease, with greater health.
Yes. I agree.
You agree?
I do. I'm trying. Yeah. There's another point that I wanted to make about just again going back to assessment and the practitioner, and there's a couple other points as to like why you might not get a referral, because we're talking about like, well, why don't people get referred, right? So we touched on education, so whether there's the proper training or knowledge bestowed in training to teach you how to refer. Another big point, which I think you wanted to touch on, was ego, just in the medical fields or both fields, all fields.
Yeah, and we're kind of talking about this. I think practitioner ego is a thing. I think it's appealing to feel like as a therapist, I can handle kind of almost anything that comes in front of me. And it's just absolutely not true. And we'll talk about this when we're talking more about the mental health side, but there's a lot of times where I refer out for like a med consult because there's only so much we can do, even with like the best deep therapies. Sometimes it's both. And so if we're looking at women and women's health and women's mental health, a basic understanding of like women's cycles in life, and perimenopause and menopause being one of them, is huge. And so practitioners, I think all would benefit from understanding that we all have an ego. If I can have an ego, you can have an ego.
Totally. Yeah.
Right?
It definitely. And just knowing to check yourself every once in a while.
Absolutely.
You do. You have to, honestly. And then the last point with like getting referral or not getting a referral is also whatever practitioner you're working with, their ability to do their own work, right? And I have some pretty like wild examples of this. I do have some patients who are counselors, and it's evident that they haven't done the work themselves in their own field, and therefore they're stuck in their own lives. And then they come to me, and I'm like, this is actually a counseling thing, and it's a tough pill to swallow to tell a counselor that you actually need counseling because you haven't done the counseling, right? But really, truly, and same with me too, is that if we're talking about myself personally or any other ND, if they haven't gone through the work in a counseling sense to help with their, past traumas and, things they've had to deal with, they're not going to be able to identify and therefore refer when someone is in a situation where that might be necessary. It's like a blind spot.
Yep.
So it's important to work with someone who really understands like holistically how things work, and that you can confidently know that they're going to be able to bring something up to you and maybe call you out if they need to.
Yeah.
Right.
And that's what we want. So kind of our last episode, which is what are the symptoms? So taking that information of what is the symptoms. And then this episode, it's like, okay, I've got these symptoms. Who do I bring it to? Is it a counselor? Is it a doctor? And then if I bring it to them, what are the ways that I can know I'm being assessed properly? Which means they're kind of taking some of those basic questions about age and cycle and periods and that kind of thing. And then the other thing is, I think being a woman is a complex thing. And I think perimenopause is often talked about and felt as like this really difficult, hard thing. It's like, I've had to get a period. If I've chosen to have children, that was, a journey. And now I'm in perimenopause and I want to murder everyone. Like, what that swear word. So what I see though sometimes is that perimenopause removes the buffer of the symptoms that have always been there. So if you have a trauma history, we get really good at just being comfortable with a dysregulated nervous system. And it's not until maybe a stage of life happens like this where that buffer is removed. And then we're like, holy F, like what is going on? And we're inundated with trauma. Or maybe our marriage hasn't been ideal, but we've been okay until a buffer's removed and we see things a little bit clearer. And so that's why regulating your hormones is good, but it's not going to help the rest of it. And so this is like coming into your like late 30s and 40s can be really freaking powerful to be like, okay, I'm going to step in and deal with this thing that happened when I was 8 because it is impacting me because trauma is treatable. And then there's so much a different life you can have, all because perimenopause knocked on your door.
Yeah, it's a bit of a unmasking. I've had patients too where like some people like they're like, this is terrible, oh my God, like help me. And then I've had others where they're like, okay, well, this is perimenopause, and they're like, I kind of like it. Like they're like, I don't want to intervene. Like I'm really enjoying this side of myself. I'm enjoying the unmasking. I'm enjoying like being more upfront and addressing things.
Yes.
So yeah, it's not all doom and gloom.
Well, and it can be a bit existential, right? Perimenopause comes with a phase of life that means that you're aging. And so that's going to make a lot of people think about like life and quality of life and mortality and a whole bunch of complex things. And for women and unmasking, society masks us to be quiet in all of those things. And if that's opening up, like, that's wonderful.
I think it's right.
Yeah. So hard, knowing the hard being the symptoms, but knowing what an assessment looks like or some of the questions that you should be asked.
Well, what assessment doesn't look like, meaning no test, like no testing for your sex hormones anyways.
Yeah.
Knowing that you're not being duped.
Yeah, absolutely. And so next time on our third episode of our 3-part series, we're going to talk a bit more about treatment. So Dr. Fox is going to talk a lot more about like, what do you do with this? So you go in with some of these symptoms, you get assessed. The conclusion is you have perimenopause. What do you do with it, right? And so we're going to talk about what she does with it, and then how can a therapist help from like a mental emotional side of things, whether that's cleaning up old stuff that needs to be done irregardless, or whether that's navigating just the complexities of emotions that are open and very alive.
Exciting stuff.
So stay tuned, and thanks for listening.
This podcast is for informational purposes only and does not constitute medical or mental health advice. We're not your doctor or your counselor. Please contact your own healthcare providers before you make any changes to your health and wellness protocols related to your body and mind.